Hello, KMC University clients. My name is Dr. Richard Mason, and in this help desk episode, we're going to discuss proper documentation of cervical disorders. Today, we're going to be targeting in on whiplash. Now, when a patient is in an accident and they have whiplash, there are critical things that need to be inside of your documentation to make your notes more audit-proof. The first thing is a clear mechanism of injury, as well as the symptom onset, the quality, the character, so that in the subjective, it tells a story of what happened, and there's detail there. The other thing that's important is to understand the functional impact on the patient. Maybe they can't sleep very well. Maybe they're having trouble turning their head and looking for traffic. That needs to be documented. When you get down to the diagnosis portion, there are certain orthopedic tests, like, for example, O'Donoghue's, that can contrast a sprain or strain. That needs to be in the documentation along with your other cervical orthopedic tests. And if they score positive on those tests, you need to document an S code for a strain or a sprain, whatever is applicable. Which leads to the next point, which is what CMT code are you going to use? Most of the time when a patient, not all the time, but most of the time, it'll be a cervical complaint when someone has whiplash, which means you're going to be using adjustments in 1 to 2 areas. So it would be a 98940. What I find as a peer reviewer, and I've done this for about 20 years, is upcoding to 98941 and 98942 when the documentation does not support that. That will definitely trigger an audit. The other thing that I see very commonly is passive modalities being used on every single visit, and each visit from a passive therapy standpoint is one visit is just the same as the next for 10 visits, 15 visits, 20 visits. When research and evidence-based medicine shows that passive modalities shouldn't be really used past 2 weeks unless there's a flare-up. The next thing that I see that is very common is there's no active care anywhere in the plan. That's important because besides the manipulation, which is passive, and the modalities, which are passive, active care not only helps get patients back to a improved functional status, better, which should dovetail into your treatment plan goals. If it's not used, the care can take longer to resolve the patient's complaint and functionally get them back to where they were. The last thing that I see, which is very common, is visits seem to go on and on, sometimes 30, 50, 60 visits for a sprain strain. And sometimes care will take more than 5, 10 visits, but rarely does it take 50 to 60. So when the visits continue in duration and frequency, that's definitely a trigger for an audit. So make sure that you document everything in your notes correctly. And so if there's any questions, you can turn your notes in and you can sleep better knowing that you've followed certain protocols and that your documentation can stand up to an audit. I hope you enjoyed this help desk episode, and check back. We're going to be doing once a month more on educational topics with clinical things happening as well as documentation. Thank you.